Welcome to the Depression Series Virtual Education Summit presented by Johns Hopkins University School of Medicine at Psychiatry Care Live. My name is Glenn Treisman. You're tuned into a live session called Case Study, a 45-year-old woman with depressed mood and medically unexplained pain symptoms despite treatment. This is with Dr. Joyce King from Franklin Square Hospital. Before we get started, I would like to remind our audience we will be taking questions in real time throughout this presentation. You can send me your questions anytime through the box in the lower left-hand side of your screen. Dr. King is the Director of Inpatient Medicine at MedStar Franklin Square Hospital Medical Center. She's Chairman of the Patient Advisory Committee. Additionally, she has written many articles on psychiatric disorders in children and adults and is interested in the role of family medicine and treatment of psychiatry and psychiatric disorders, and has been actually a contributor to this program and others with us. So I really want to thank you for coming, Dr. King. Also joining us is Dr. Michael Clark. He is the clinical director and vice chair for clinical operations, is that right? Here at Johns Hopkins, and has been my partner in running the chronic pain service for many years. He is one of the frequent contributors to this program also, and I was able to get him to come and join us because I thought it would make the discussion more fun. And since this is going to be mostly about the discussion of this case, more was better. So thank you, Dr. Clark, for making the time, and Dr. King, thank you for getting away from your busy time at the hospital at Franklin Square to come over and join us. We're going to present your case for a few minutes, and then we'll have conversation.
I'll go ahead. I'm going to be talking about a real case today, which is always much more fun. In this case study, we're going to be talking about the patient who has multiple somatic complaints, and these are predominantly pain complaints, but a lot of this case applies also to patients who have somatic complaints that aren't pain-related. So CS is a 45-year-old woman who presented to the office initially after a motor vehicle collision with the complaint of low back pain. She was treated with nonsteroidal anti-inflammatory analgesics, moist heat, muscle relaxants, and a recommendation for graded increase in physical activity. As you well know, the practice of telling people to rest in bed in the past has fallen away, and really we recommend that people increase their physical activity. After about 3 weeks, she came back in stating none of those things work for my pain, and, quote, I need something to take so I can get some sleep. She was offered a prescription for tramadol or acetaminophen with codeine as sort of the next step up from the NSAIDs, but she stated, I've tried all of those, none of those work. So she was given a prescription for oxycodone and referred to physical therapy. As many primary care providers know from our case so far, this is probably a good 25 to 30% of the acute care types of complaints that come into their office. At physical therapy, she did receive deep heat treatments, ultrasound, massage, traction, and exercise therapy, but after a few visits, she failed to show up for 3 visits, so physical therapy discharged her from their treatment program. A review of her past records reveals that she's had about 6 visits to the doctor's office in the past year and 4 visits to local emergency departments within that same past year. The visits to the office have all been for acute care. They've been scheduled with the physician's assistant, they've been scheduled with the nurse practitioner, and really not ever with her primary care doctor. All of those visits have also been for pain complaints. A couple of them, of course, for follow-up from her visits to the emergency department. During those visits, she has had various complaints. She's complained of headache, chest pain, neck pain, migraine, low back pain, abdominal pain, and pelvic pain. Dr. Clark is recognizing this case. He has seen many of this kind. And really, the saga is quite distressing because not only has she had a year of dysfunction, but she has also undergone a plethora of medical tests. She has had lumbar spine x-rays. Those were interpreted as normal. She's had cervical spine x-rays, which showed mild straightening. As we know, a lot of troubles just with muscle tension and muscle spasm in the neck can cause straightening of the cervical spine. She's had chest x-rays, ECGs that have been normal. She even had a brief stay in observation in the hospital where she had cardiac enzyme testing and a graded exercise treadmill test with nuclear medicine imaging that was negative for prior infarct or for inducible ischemia. She underwent a chest CT angiogram, which was negative for pulmonary embolus or aortic dissection. She had an abdominal CT scan with oral and IV contrast. Now, that did show gallstones without wall thickening or pericholecystic fluid, so probably not a clinically significant finding. Lumbar spine MRI had been done, and that showed mild degenerative disc disease. Probably all of us over the age of 40 have that, but no significant stenosis or foraminal impingement. She'd had pelvic ultrasound that showed a normal uterus and a 1 centimeter follicular cyst on her right ovary, which is also a normal finding. She had ultimately undergone pelviscopy, so she'd had an invasive procedure and had had, quote, lysis of adhesions, unquote, which we're really not sure of the significance of that. Because of her neck pain complaint, she'd had EMG and nerve conduction velocity testing. That was also reported as normal. Because of that abdominal CT scan finding, she was actually referred to and seen by a general surgeon for consideration of cholecystectomy, but her HIDA scan was normal, so this was deferred. Bravo to the surgeon for not doing a surgery. Because she had received an opiate prescription, it's the practice in our institution that she then has to have a visit with her primary care physician. And this is a policy in place to avoid patients seeing a PA, a nurse practitioner, a different person every time. And if they have received opiates, that they would follow up with their primary care physician. So at the point where she's following up with her primary care physician, you have the chance to review and really take a structured clinical interview, which is what we recommend. She's married. She has 3 children, ages 17, 14, and 11. She completed high school, but she gives the history that she really had academic struggles to finish. She tried to attend some college. She's a non-smoker. She denied any illicit drugs. She reports that she drinks alcohol, quote, when my headache or backache is so bad that I can't sleep. She's worked in food service, she's worked as a nurse assistant, she's worked as a teacher's aide, but she's now driving a school bus, which actually is the best job in her report that she's had because her time can match her children's school schedule a little bit better than the other jobs. When taking a family history, you realize she really has a strongly positive family history, although it's not stated in that way. Her maternal grandmother had a stroke, maternal grandfather had heart disease, but her mother died young and she really can't explain the cause. It's just described as an unknown cause. Her father had alcoholism and died of cirrhosis. She has a brother who took an overdose of illicit drugs. She can't describe anything more about his psychiatric history. And she has a sister who she, although doesn't use the word depression, her description of the sister's clinical course is consistent with depression. The patient, has never been diagnosed or treated for depression. Her medication list includes naproxen, 500 milligrams twice daily, acetaminophen, 500 milligrams, and she takes up to 8 pills daily. She describes that there are times when she takes 4 pills at a time. Diclofenac gel that she rubs on painful areas as needed. Lidocaine patches to painful areas, 12 hours on and 12 hours off. And she ran out of oxycodone several days before the appointment. The PHQ-9 test, if anyone's familiar with it, is not really a diagnostic instrument in my opinion, but it is a nice tool to rate someone's symptoms in a way that they can relate to and that then you can follow as a way of showing them that they have improved or not. Her PHQ-9 score is 20 at the time of this visit, which is quite a high score. She denied any suicidal ideation. So as you put all these things together in this case study, you realize that this woman has had a year of real dysfunction, probably a lifetime of struggling with a disease that hasn't been diagnosed. She's very resistant to calling it depression, but she's willing to consider treatment in case it could help her pain, because what she's really focused on is her pain complaints, and really her pain